And so the name of this discussion is about diffuse traumatic brain injury. And we're going to discuss how to identify, how to assess, and how to document and how to treat diffuse traumatic brain injuries. Now, diffuse traumatic brain injuries are a challenge in and of themselves. Why? The brain is encased in this bony cavern, and you can't see it, right? Well, you can see it with a CT scan, but when you're first assessing the patient, um, you can't see the injury. So, what you have to do is you have to listen to what the patient is saying. So, if the patient is saying things that suggest that they have a memory problem, then you think it's the hippocampus, right? If you think the patient is having, perceptual disturbances, like they interpret reality different than you, or their reality is so different that you can't understand how they came to that conclusion, that may be the prefrontal cortex. If they start having like impulse control issues, attention to concentration issues, planning problems, then that may be the frontal lobe. So even though you can't see the brain, for a person who's experienced a significant head injury, you can sort of listen to them and examine them to sort of see the areas that are most likely impacted. If you understand the networking and the blood supply and things and what that area is responsible for, then you'll probably get a good idea of what you're going to use as medications to help treat. So, for example, if the patient's hippocampus is malfunctioning or is damaged and they're having difficulty with memory, of course, you want to use the medication to help the patient with memory issues like Aricept, memory medications, right? If the patient is having rage attacks, secondary to damage in their temporal lobe and things like that, something similar to temporal lobe epilepsy or word finding, speaking difficulties, then you think that's the temporal lobe. And you may want to put the patient on something like a mood stable, like Depakote, to decrease all of that seizure-like activity in that in the temporal lobe that's creating all the agitation and aggressiveness. If their frontal lobe is hypoactive and they can't pay attention to concentrate, you may want to start a stimulant, right? If they're having psychotic symptoms like hallucinations, delusional, disorganized behavior, you may want to you may want to prescribe an antipsychotic because it would block all those dopamine pathways, right? So with a diffuse traumatic brain injury, that means, imagine like a motorcycle accident, right? Inside the brain is a sponge and it batters back and forth inside this cage, creating coup and then contra coup injuries, coup and then contra coup. Coup when it hits forward, when the brain hits something, the skull hits something, the brain moves forward and hit the anterior wall, anterior surface, the anterior part of the brain in this coup injury. And just like the sponge, it is that wave ripple back and it can hit the posterior aspect of the skull called a contracoup injury. And you can get injuries flipping over on the motorcycle, rotational stalk injuries, hyperextension, overextension, rotational injuries. These rotational injuries could be very damaging because you're stressing these structures that are right there at the stalk. So you're stretching all of these structures and you're interfering with these huge bundles of fibers that go and do things. And so those rotational like injuries can be very devastating, right? So what we're going to do here is let me search. Let me search something. Let me see. What am I searching for? Okay. Let me do all these things. Okay. Let me go ahead and search. Explain the assessment. Okay. Explain the assessment and treatment of diffuse traumatic brain injury. Oh, my. Let me see what they have here. Oh, let me go through this first. Pretty good example. Yep. Pretty good example here. See, I get all mine for free. I just go in and get out. Go in and get out for free. Okay. Here's the wall. Okay. Here's the brain pushing forward and hitting the internal surface of the skull. And just like gelatin, it pushes, comes back, and you can get a second injury when the sponge hits the back injury of the skull. Now look at all of these layers here that becomes disrupted. Look, this is the axon shear here. At that differentiation between the gray and white matter here, the severing can occur at this point, severing the neuron in half, right? This is very dangerous and it can occur in multiple locations. Why is this dangerous? Then the damage and the death of the cell leads to a loss of all of the content in that space. And so you get the release of all of these molecular molecules in that place and all of in this space, and all of these things do things. They're all active. So the content inside of the cell is considered more toxic outside of the cell. You don't want all those things outside of the cell because they're very active. You have a factory with no windows and no doors, right? And remember the rotational stalk injury? Yeah, that shearing effect, that shearing effect can be very dangerous. Let's see here. Okay, this is great. Wow. Hey, look at this. It's great. Diffuse axonal brain injury. Hey, all right. Injury attorneys. You mean that I got to get my reference material from injuries attorneys? No, I'm not doing this. I'm not getting my material from an injury attorney. No, the stuff is nice. His or her stuff is really nice. Okay. Anatomical Justice. Is this another legal site? Man. Okay, you'll see Anatomical Justice. Okay. Whiplash. Here, subdural hematoma. Right? A subdural. So this gray part, okay, yeah, the gray part there is the subdural hematoma. Look, here's your dura, brain, the skull, the bridging brains. Can't really see them that well, but it serves its purpose. Look here, you have subdural hematoma. So the effects of diffuse traumatic brain injury on the brain cells. Great. Axonal shearing occurs during hyperextension or hyperflexion injuries. Okay, shearing. Axon terminals pulled away from synaptic junctions. Wow. Wow. That's the first time I've heard of that one. Of course, the axon, then the axon terminals. Okay. And here's the shearing. Oh, okay. They say retraction ball here. Necrosis of the cell body and dendrites. Yeah. And then when the cells die, they're not replaced, right? Then there's an entire process that takes place after the cell dies. In order to clean up all of this, you have your immune system that picks up the damage, and then it starts to recruit it recruits an inflammatory response, which recruits more of the white blood cells to sort of help manage this thing, help clean this place up. In order to increase the inflammation, it has to make the blood-brain barriers porous. And because the blood-brain barrier are porous, now you get the state of sort of confusion and sort of like a diminishing storm, difficulty focusing, difficulty concentrating, difficulty thinking, because that inflammation, the inflammation interferes with how all the networks function. because the inflammation makes the blood-brain barrier porous. The blood-brain barrier is supposed to be semi-porous. It's a semi-permeable membrane, meaning it only lets specific items through. However, after the inflammatory response to an injury such as this, it must increase the inflammation in order to get the immune system there, in order for the immune system to start to react to this event. And the inflammation itself causes dysfunction with the neighboring circuits around it. And the inflammation itself can also promote and encourage more brain cell death. So the death of the cell leads to the death of the cell leads to worsening inflammation, and that inflammatory response, although it's there to help you, it also causes damages also. This is a tough situation to be in, you know. Anatomical justice. Let me get off this page. Why do the attorneys have better diagrams than the doctors? Let me look here. Oh, these are for sale. Those are, I don't, let me get off the attorney website. All right, so here. Okay, then let me look here. What is this? Classification of traumatic brain injury. Okay. Okay, types of brain injury. Diffuse, and this I'm talking about here. Focal, right? Diffuse, a concussion. Remember a football, a helmet, a foot getting knocked unconscious with football, or falling off a motorcycle with a helmet, right? Diffuse axonal injury, the blast, right? Abusive head trauma, shaken baby syndrome. Yeah, head trauma, shaken baby syndrome, a blast, a diffuse axonal blood, diffuse axonal injury, and a concussion. So these are all the different things that can create a diffuse traumatic brain injury here. And then focal, like contusion, get hit on the head with a ball, penetrating gunshot wound, epidural, right? Then you can get a hematoma located in the epidural space, the subarachnoid space, or subdural. So, but these are so a hematoma could create a focal injury because it can still lead damage to the tissue, like intravesicular, hematoma, also intracerebral, intraparenchymal. And so these are all the focal subtypes of a diffuse traumatic brain injury. Yeah, this thing is helpful. Okay, let me see here. Okay, here. Diffuse traumatic brain injury, especially diffuse traumatic axonal injury, is assessed by monitoring vital signs such as the Glasgow Coma Scale. Ooh, hold on one second. Telemarketer. Okay, yeah, the Glasgow Coma Scale, right? Performing neurological evaluation and using images like CT scan or MRI to check for widespread damage. And you want to see inflammation, right? Treatment focuses on preventing secondary injury by optimizing oxygen levels, maintaining blood pressure, and managing intracranial pressure. Long-term care involves a multidisciplinary team, a specialist providing physical, occupational, speech, psychological, and cognitive therapy to help the person regain function and return to a normal community. Just look at these areas: long-term care, multidiscipline, right? Specialists, okay. Physical therapy, getting in shape. Occupational therapy, learning how to work around the house. Occupational therapy, learning how to get around the house, speech therapy, because it can be in the area of age of speech. Psychological, right? Because it can be in that prefrontal cortex, affect your perception of things. Cognitive, it can be in your frontal lobe. And so this multidisciplinary team will focus on the different aspects of the person's care. Um, let's look here, the assessment, the initial pre-hospital evaluation session, of course, vital signs. Look, Glasgow Coma score, a score out of 15 to assess the level of consciousness. Now, the higher the Glasgow Coma score, the likely the severity, the likely the severity of the symptoms associated with the diffuse traumatic brain injury. So if a patient had like memory loss, like if they had a diffuse traumatic brain injury, and you're talking to them a month later, you say, okay, well, do you remember the events that led up to the accident? I don't remember. Retrograde amnesia. Well, do you remember what happened when you woke up in the hospital? Yeah, I woke up in the hospital. My mom and pop was there, and we were talking about things and everything like that. So no anterior grade amnesia. So with the diffuse traumatic brain injury, look for the retrograde amnesia. Did they remember the things before the accident, or the anterior grade afterwards? And so, great. Next, pupil examination, pupil dilation. See if those those tracks are functioning well. Get the patient history, gather information about the injury, and if consciousness was lost. Okay. A medical evaluation, so of course, neural exam, CT scan most likely, blood tests. Right. If they come in confused or agitated, you're going to need blood tests to see what's going on. Right. Treatment, acute and supportive management, and then long-term rehab. Look, oxygen and ventilation, stabilize the blood pressure, prevent other problems by managing everything correctly, right? So you don't want a fever, you don't want high blood sugar, things like that, Long-term stability. Again, the multidisciplinary treatment approach, physical therapy, right? Occupational, getting around the house, speech, communication, cognitive, alertness, awareness, psychological counseling, support, vocational counseling, basically start getting, being able to assess the person's skills and sort of help him get back to work. Here, now let me see, explain the Okay, let me see if they. Of course, the treatment is going to be whatever's in front of you. Basically, you're going to have to put together a combination of medication to make things work right. Medications for diffuse traumatic brain injury target specific symptom complications, including anticonvulsants for seizures, particularly if it's in more of the temporal lobe where there's intense anger, diuretics to reduce intracranial pressure, pain relievers and headaches, antidepressant if they're very depressed, anti-anxiety agents. But with diffuse traumatic brain injury, I recommend try to stay away from narcotics because they have difficulty controlling the impulses. So if they start using a narcotic, then they may not be able to stop because they don't have the frontal lobe power to suppress that impulses. Does that make sense? And stimulants to improve alertness and focus. Other medications include muscle relaxants, anticoagulants, and medications like amantadine for cognitive and behavior issues. Okay. Medications for acute symptoms, such as medications for acute symptoms and complications. Diuretics, lead that to the other team. You have your anticonvulsants. I prefer Depakote, anticoagulants. We leave that to the medical team. Osmotic agents, the medical team. Management long term. Yep. Same thing. Okay. Let me look here. The choice of intensity of medication depends on the type of severity. Let me look and see if they come in anything on the severity of TBIs. What type of TBIs are medications? Medications administered for traumatic brain injury depends upon the type of injury, its severity and results. Functional impairment. Medications also vary on the stage of treatment, which includes acute phase of treatment immediately after the injury and a long-term management complication of chronic symptoms. Okay, so same thing. Osmotic agents decrease the height of pressure, anti-convulsant, make sure their electrolytes are bound. Now, look at this. NMDA receptor antagonist. NMDA is a type of glutamate receptor, and glutamate is excitatory. So they want to not use anything that's going to excite glutamate because that's going to make it more hyper. We want to go with, we want to reduce it. So barbiturates, I wouldn't use those. Long-term managed stimulants, because you may need to stimulate the frontal lobe. If the frontal lobe is in hyper, if the frontal lobe, just like if the frontal lobe is damaged and it's not as active, then you have less executive functioning symptoms. You become more inattentive and easily distracted. That's why in children with ADHD, we give them stimulants to stimulate the frontal lobe, not to stimulate the whole body, to stimulate the frontal lobe to become more active. So the frontal lobe processes more information, and therefore the patient reacts because they're processing more information. So that's what the stimulant is for. Now, remember, dopamine antagonists. Remember, the diffuse traumatic brain injury can damage the major pathways. If you get damage to the mesocortical pathway, it's going to bounce up and down. When that mesocortical pathway bounces up, you're going to get positive symptoms. When it bounces down, when it becomes hypoactive, you get negative symptoms. And so during the day, if the diffuse traumatic brain injury, let me show you what I'm talking about here. Okay, mesocortical pathway. Just look here. This pathway here, come on, give me for free. Come on. Give it to for free, yeah. Y'all can get it for free. It's educational purposes. So this is the major nerve bundle in your brain called your mesocortical pathway that's primarily responsible for the symptoms of autism and schizophrenia. If the diffuse traumatic brain injury damaged this root at the stalk, then the entire network becomes unstable, meaning it's no longer regulated, meaning there are times when the network becomes hyperactive. When this mesocortical pathway becomes hyperactive, you get positive symptoms of schizophrenia. When it becomes hypoactive, you get negative symptoms. And so an injury, diffuse traumatic brain injury, can switch this network on and off. And so the patient presents agitated, psychotic, then withdrawn and apathetic and avoidant and things like that. Now, that's just that pathway. And look how far it extends all the way up here to the frontal lobe. This pathway right here, the mesolimbic pathway, is the pathway of target for all the drugs of abuse. Hyperactivity in this creates the intoxication that every cocaine person who's addicted to cocaine uses. So the addiction to cocaine is secondary to the need to keep activating this mesocortical pathway. Now, during drug withdrawal or cocaine withdrawals, they typically have the exact opposite symptoms. The fatigue, the anhedonia, decreased interest, decreased motivation. You get injury to this mesolimbic pathway, it'll be hard for the person to experience your pleasure, dysphoria. They'll keep popping back and forth, happy, sad, it's just to be a mess. And so you can see how the diffuse traumatic brain injury damaging these major nerve bundles can create complications due to overactivity and then suddenly hypo or underactivity. And take that throughout all the networks in the brain. And there you see the complexity in treating diffuse traumatic brain injury. So what I do is sort of like look at the area of the brains that's not working well. If it's not the hippocampus, if the memory is not working well, then we need to work on work on the hippocampus. If their perception is off, we need to work on this mesocortical pathway. If they seem like they're withdrawn, hypoactive, no interest, motivation, we need to pump up the mesolimbic pathway. So I sort of look at these different parts of the brain and the pathways to sort of try to figure out a way to stabilize all of this symptomatology, right? And so things like Depakote mood stabilizers are always used first, and then try to target the hippocampus with things like acetylcholine and increase the acetylcholine in those parts of the brain. I think that's all I want to say here about diffuse traumatic brain injury. And if you have any questions or anything like that, please feel free to put them in the comment. If not, yeah, it's a pleasure talking to you. Take care, guys. Read out. Ciao. Today, we're going to have an interesting conversation about liver enzymes, ALT, specifically ALT and AST. And for the most part, it's important to review your liver enzymes because the liver is the location where all the metabolism of the medications are happening, all the drugs. Also, you're going to need the liver to metabolize the drugs that are active. And also, for prodrugs, you're going to need the liver to create that, metabolize that process in order to release the active metabolite. So it's important to know the function of the liver enzymes. Other day had a patient come in with significantly elevated liver enzymes and had to figure out what was going on, right? So let's see here. Okay, here, explain the explain AST. What am I doing? AST and ALT lab. What if each was my words? Lab values and elevated liver enzymes. You busted me out. I'm a horrible typer. You busted me out. Okay, let me see here. Okay. AST, aspartate aminotransferase, right? ALT, alanine aminotransferase. Okay, these are liver enzymes that's measured in blood tests to assess liver function and liver cell injury. When liver cells are damaged or die, these enzymes leak into the bloodstream, causing elevated levels. You got it? When liver cells that are damaged or die, the AST and ALT are leaked into the proteins are leaked into the bloodstream, right? Okay, here's how to interpret them. The normal range, AST 10 to 40, ALT is 7 to 56. Okay, can value. ALT, alanine aminotransferase, is primarily found in the liver. Now look at this. AST, aspartate aminotransferase, is found in the heart, in the liver, the heart, the muscle, the kidney, and the brain, right? So ALT, alanine aminotransferase, is specifically for the liver. So when you see that elevated, then you know for definitely you've gotten some hepatocellular injury, right? So more specific for injury is when ALT is elevated, it usually means hepatocellular injury, that is damage to the liver cells themselves, right? For example, in the viral hepatitis, right, and the drug induced damage, fatty liver disease, such as alcoholic and alcoholic steatosis, right? The excessive alcohol intake causes a fat malfunctioning in fat metabolism. As a result, you get a buildup of fatty deposits, causing steatosis and fatty liver disease. Next, so this ALT think is hepatocellular, the liver damaged cell. AST, aspartate aminotransferase, is found in the liver, the heart, the muscle, kidney, and the brain. It's less specific for liver injury, all right? And it can be elevated in muscle damage, myositis trauma, or cardiac myocardial injury. So AST, so when I see an elevated AST, I know there's a major organ system issue, right? It's a major organ system issue. Often elevated alongside ALT and disease. Okay. The AST-ALT ratio, this ratio helps narrow down the cause of enzyme elevation. Okay, less than 1, viral hepatitis or non-alcoholic fatty liver disease. 1-to-1, cirrhosis. 2-to-1, alcoholic liver disease, such as AST is over ALT. 3-to-1, Wilson's disease or secondary muscle source. Well, Okay. Elevated pattern, mild elevations, fatty liver disease, chronic hepatitis, medications, okay, so patterns of elevation, mild elevation that is less than 5 times the normal, fatty liver disease, chronic hepatitis, medications, moderate elevation, 5 to 10, acute viral hepatitis, autoimmune, and severe pattern greater than 10, acute toxic injury, such as acetaminophen overdose, ischemic toxic injury, hepatitis. Yeah. Other liver tests interpret alongside ALT. Yep. See, alkaline phosphatase. Remember biliary injury or obstructions. So remember, in alcoholics, the lipid, the metabolism malfunctioning, leading to basically the buildup of bile and increase in alkaline phosphatase. Okay, bilirubin is impaired. Albumins, liver. See, albumin. You have to look at the albumin, because if the liver isn't producing enough now albumin in this, you're not creating enough proteins, right? So that's like fulminant. That's a significant form of failure, liver failure, if your albumin is dropping, because that means that your liver is not producing the proteins. Yep, and then prothrombin time. You would need to produce the proteins and things like that in order to run your the clotting factors and things like that. Okay, summary. ALT is specific for the liver, high specificity. Is seen in viral hepatitis, fatty liver, and drugs, because all of these damage the hepatocyte directly. AST is found in the liver, the heart, and muscle, right? Alcohol and liver disease, muscle injuries. If AST is twice the value of ALT, it suggests alcohol liver disease. All right. I think that's all I wanted to say about those AST, ALT values, and more importantly, how they're used in diagnosis and treatment. So I think that's all I wanted to say about that, guys. Now, next, I'm going to go to I think the other topic I'm going to do next is, let me see here. Okay, well, I'll just show you the next. I'll just do the next one. I'll do the next. So stay tuned for the next one, guys. Take care, guys. Read out. Ciao, guys. Hey, guys. Reed here. Today, we're going to have a very interesting conversation about lithium, right? Lithium is an amazing medication. It's one of those medications that has a bad rep, but it's used so many times, and it's used in some of the most complicated cases. But lithium is an amazing medication, and I think you should know the mechanism of it, so you can see how much benefit it can have. Now, lithium is an anti-manic medication. It's an anti-manic agent, and lithium is an ion. It's not a compound, so it doesn't need to be metabolized. It simply needs to be secreted, like lithium, salt, sodium, potassium, all of those. Right. So lithium plays a very important role with augmentation. Like if you have a patient that's on your, let's say you have a patient who's you're treating for depression, and you have the person on an SSRI. You start the person on the SSRI, and you get a little response. You increase it, you may get a little bit more response. You increase it more to the maximum, something like that. You may not get as much of a response. What do you do there? Well, you want to see about using lithium. May consider using lithium in that supplementation situation as an augmentation strategy, right? And the reason why is this. Let me show you, let me sort of show you how this sort of works, okay? Okay, what am I looking for? I'm looking for, let me give you an image of the image of synaptic cleft. Okay, let's see. Let me pull up this one here. Okay. Here's a presynaptic neuron right here. Here's the postsynaptic neuron right here. Presynaptic, postsynaptic. Okay, now here, okay, great. Here, the ligand is binding the receptor. And after the ligand binds the receptor, then there's a 3D configuration change in the receptor, right? And that leads to the signal transduction cascade that sends the message to the cell body on what we want what this ligand here, this molecule, is intending to have the cell produce. So this molecule is binding to the receptor to translate a signal to the cell body to produce more of X, right? In the situation that I described where the person is on an antidepressant or something like that, and we have basically all the receptors bound, but there's no response, it could be that the signal transduction cascade, the inner signal, is malfunctioning, right? So we can not only get one, so we think that once the ligand is bound to the receptor and when the receptor is activated, we think that we're going to get a response for the cell. But what happens is the mechanism that transfers the signal could be disrupted, and that's what lithium is for, right? So you're giving someone medications and the receptors are not working. So you give them lithium. Lithium works on that signal transduction cascade after the reception. And that's what we're going after the receptor. And this is what we're going to look at the signal transduction here. I hope you got that. Okay. So let's look here. Let me see. Okay, explain the signal transduction cascade when ligands bind G protein receptors. Okay, here's the signal transduction cascade. Let me see if before I go here, let me just try to pull up an image of the signal transduction cascade so you know what I'm talking about. Signal transduction cascade, let me see here. Okay, what am man, they doing this in Khan Academy? Okay, here. All right, and so here are the here's example here. Here's this, I guess this is the postsynaptic receptor. It could be the presynaptic receptor, but here are the ligands, right? They're binding the proteins, and this is resulting in a series of reactions that release two subunits, and those subunits become active and start doing here. But I never remember, I have to go back and always remember the things here, but but you can see what's happening here. Oh, okay, so this is interesting that this, I never, somehow, I never placed the signal transduction cascade within the plasma membrane. I thought it was inside the, okay, no, oh no, this is the nucleus. Okay, yeah, okay. No, here's the, it is, right, it's the plasma membrane here, here's the cell, this is the nucleus here. So here's the receptors. This is the signal transduction cascade that go ahead and sends the signal here, phosphorylation. So let me go ahead and go through this. I think I have a better example than this one. But you see what I'm saying? This, when you can get to a certain point where this pathway isn't really working well, and this is one of the reasons why you want to sort of use lithium. Look, here's the signal here, here's the receptor, here's the conformational. It starts off with this, then it's conforming to this, then it's conforming to that, and then it's going to send this message to the cell body, and the cell body is going to produce something and then have it exported out of the cell body. So this is a signal transduction pathway I'm talking about. I don't think it's very necessary to get into. I don't even remember all the. I look at it for years and everything. Just don't stick to memory. But this is the pathway here, and this is what you want to use lithium to sort of help work on if you are not getting a good response. Okay, so I think I got that. Okay, here, explain the signal transduction cascade when ligand binds G protein receptors. Excellent questions. Let's break down the signal transduction cascade that occurs when a ligand binds to G protein couple receptors. Now, I specifically put G protein couple receptors, not ionotropic receptors that turn on and off. Like those gate controlled and ionic controlled, not those. Those just turn on and off and deal with the currents that's coming across to maintain that action potential, right? But I'm talking about the G proteins that are there to take the signal so that you can produce things from the cell. Okay, so my search was specifically for those. G protein couple receptors are membrane proteins that convert extracellular signals like hormones or neurotransmitters into intracellular signals via G proteins and second messengers. You got me now? Right. The key steps are the ligand binds to the G protein receptor. The G protein receptor activates a G protein, right? So you have the G protein receptors, and it has two subunits that are inactive when it's bound to it. The configurational change results in release of the two subunits, and they go on and start doing their thing, right? Okay, so G protein activates or inhibit an effector enzyme or channels. Right, okay, yeah, see, the G protein can turn off or turn on these ligand-gated or ion channels, right? Ion channels here. And then also, this signal transduction cascade typically results in the cell producing something that's going to be exported out for the cell's functioning, right? Then you get a cellular response, then the signal is terminated. Okay, those are the steps. So here, that's step one. Step two, receptor ligand binding. The ligand signal molecules such as epinephrine, dopamine, serotonin, or acetylcholine bind to extracellular domain of the G protein. Okay, the ligand binds. The receptor changes shape. That means there's a conformational change. The conformational shifts alters the cytoplasmic side of the receptor, allowing it to interact with a nearby heteromeric G protein. Yep. Let me show you this. Let's go this again. The conformational shift alters the cytoplasmic side of the receptor. So remember, the ligand is on the extracellular. It binds to the extracellular domain, right? And then the conformation alters the cytoplasmic side of the receptor, allowing it to interact with their nearby heteromeric G protein, right? Okay. Activation of the G protein. G proteins are heterotrimers with three subunits alpha, beta, gamma. Okay. In the inactive state, the alpha subunit is bound to GDP. When the GRAC protein is activated, it acts as a G-guanine nucleotide exchange factor, causing the alpha unit to exchange GDP with GTP for GTP. This activates the G protein. The alpha subunit dissociated from the beta dimer, and both can signal independently. This is the G protein right here, activation. Yeah, look, effector activation. Yep. The active G alpha or the gamma or beta complex interacts with downstream effector proteins, such as GS stimulatory, G inhibitory, phospholipase, these channels. Okay. Second messenger generation. Effector enzymes create second messengers, which amplify the signal. Effector enzymes create second messengers, right? So if you have a ligand that's going to activate the receptor, then these second messengers is going to amplify the signal what they want. Adenylate cyclase produces CMP, which activates protein kinase A. Phospholipase C splits into PIP2, PIP3 phosphate inositol triphosphate triggers calcium release from the endoplasmic reticulum. DAG, what was it? DAG activates protein kinase C, and then ion channels alter membrane potential and carry and calcium entry. Next, you also have a cellular response. Activates kinases, phosphorylate target proteins. I'm sorry. Okay, let me slow down. Okay, here. Okay, here's the, okay, this is the second messenger generation. Okay, and then here's how the cell responds. Activated kinases, such as phosphorylate target proteins, the kinases phosphorylate target proteins, and this alters the enzyme activities. Again, gene transcription, ion channel conductions, and the cellular metabolism, secretion, or contraction, etc. Now, see, 6 is the point where the cell actually responds. So with all of these kinases activated, you get phosphorylation of all of those target proteins. And as a result, it results in a change in enzyme activity, a change in gene transcription. These are the new genes that we want to have expressed. A change in ion channel conductance, meaning changing the action potential. And this results in metabolizing, producing, and taking in other substances from the cell. Okay. Next, signal transformation. To prevent overactivation, the G alpha subunit hydrolyzes GTP to GDP. And via intrinsic GTPase activity, also often accelerated by RGS proteins. Right. Okay. So the alpha subunit has an intrinsic GDPase activity, and so therefore, it's going when it's released, it's going to convert GTP to GDP and therefore deactivate itself. Alpha GDP reassociates with the gamma and it activates the G protein, right? So that gamma subunit has has intrinsic GTPase activity, and therefore when the alpha subunit is released, there's only a matter of time before it cleaves the bond between GTP to GDP, and therefore it causes a reassociation between the alpha and gamma subunits, and then therefore we have inactivation of the G protein. Got me? Okay, let me see here. Okay, where were we at? Okay, and so here's how the signal is terminated. I think that's all we have for today. I think that's really reason I wanted to sort of use lithium. Okay, I hope that's clear for you guys. Okay, let's see here, and then let me know if you guys have any questions. Again, if you do, it's a pleasure. Otherwise, I'll talk to you guys later. Okay. Take care, guys. Take care, guys. Today, we're going to have a very interesting discussion: alcohol, hepatitis, and cirrhosis of the liver. Now, when you're running across patients who have alcohol dependency issues or who's been diagnosed with a history of cirrhosis of the liver, it's important that you understand how to prescribe your medications and what to think about, because overall their liver no longer has the capacity to process things at the same speed. And so you're going to have to select medications with shorter half-lives, select medications that's likely not to lead to any type of addiction, select medications that's probably can avoid the liver and be simply secreted through the kidneys, and also to avoid medications that would need to be a prodrug, because if it's a prodrug, then your liver will not have enough cells to sort of release the prodrug to its active form. So if the liver is damaged to a way that doesn't have enough protein to convert your prodrug to its active metabolite, then those medications may not work as well. So there's a few things to understand here in alcoholic hepatitis. So let's go ahead and just look at, let me just say here's Chat GTP. Explain alcoholic hepatitis. Let's see what I have to say here. Okay, so pathophysiology, the clinical features, the laboratory features, histology, complications, management, prognosis. Hey, yep. Would you like me to include how alcoholic hepatitis different from drug or what you call it? Yes. Yep. Yes, let me. Okay, if you think about those while I'm up here. Okay. So here, alcoholic hepatitis is an acute inflammation of the liver caused by heavy and prolonged alcohol use. Heavy and prolonged. It represents a serious form of alcohol-related liver disease and can range from mild to life-threatening. Yep, life-threatening. Pathophysiology means what happens in the liver. The ethanol metabolism, the oxidative stress, the immune reaction, right? The fat accumulation, and then finally the cell death that leads to fibrosis, right? Leading to cirrhosis. Alcohol metabolism, the oxidative stress, the immune reaction, the fat accumulation, cell death, then fibrosis. See that? So that fibrosis, so cirrhosis of the liver is the buildup of that fibrous tissue. And so that means the liver is typically smaller and is less like a sponge, because of the buildup of the fibrous tissue. That's why it's cirrhosis of the liver, right? So alcohol metabolism in the liver produces aldehyde, a toxic compound that damages liver cell membranes and mitochondria, and it promotes inflammation and fibrosis, which is scar formation. See this, the buildup, the alcohol causes the buildup of acetaldehyde. It causes damage to the liver cell membranes, damage to the mitochondria, and it also promotes inflammation, which eventually leads to fibrosis. So that mechanism is the buildup of aldehyde basically leads to the scar formation. Oxidative stress. Alcohol metabolism increases free radicals, which injure liver enzymes. Right? So the oxidative stress, alcohol releases. So first, alcohol causes buildup of acetaldehyde, which damages the brain cell and membranes and mitochondria. And then it also causes inflammations, which leads to fibrosis, there's a scar formation, and the oxidative stress by increasing free radicals that injure the cell. Then the immune activation. The damaged liver releases signals that activate inflammatory cells such as neutrophils, cytokines, and tumor necrosis factor. So now the immune activation, so now you have all the stress. Steatosis, fat accumulations because alcohol disrupt lipid metabolism. So fat accumulation, lipid metabolism. Then you have cell death and fibrosis that progress, possibly leading to cirrhosis of the liver. You see that mechanism right there? So I see the aldehyde buildup damages everything, the free radicals, right? Damage everything. Then the damage to these create an immune reaction that leads to an inflammatory response that eventually results in disruption of lipid metabolisms. All this results to cell death and then fibrosis, and then that cycle continues to release itself until you have more cirrhosis of the liver, right? Sounds good. Clinical features. Symptoms can appear suddenly, often after a binge in someone with chronic alcohol use. Yeah, right. Jaundice. Yeah. Alcoholics like the jaundice in the eyes, the jaundice, the buildup of fat. Right here, yeah, because alcohol disrupts the lipid metabolisms, jaundice, right? You get that fever, I guess, abdominal pain, except the upper right Clinical features, fatigue and weakness, yes, nausea and vomit, hepatomegaly, meaning enlarged liver. Signs of liver failure include ascites, confusion, and bleeding tendencies. All of these are the clinical features right there. Next, laboratory findings. The typical lab finding, AST is elevated more than ALT. Both elevated, but typically more than 300 AST to ALT ratio. So in alcohol, basically, the AST is significantly elevated more than the ALT, right? And there's a reason for that, right? AST versus ALT, right? Elevated bilirubin, okay, a prolonged IMR, okay, since indicating impaired liver synthetic function because it's not producing the albumin, right? Leukocytosis, leukophil predominance because of the immune response. Macrocytosis, that's enlarged rail cells due to alcohol. Yeah, the macrocytosis on the skin. Elevated GGT. Okay, yeah. Okay, those are liver findings. The histology. Ballooned hepatocytes, which are swollen cells. Wow, swollen cells. Ballooned hepatocytes. Mallory-Dink bodies, damaged cytoskeletal. Mallory-Dink bodies, damaged cytoskeletal proteins. Neutrophil infiltration and paracentral fibrosis, zone 3 fibrosis. Okay, histology. Okay, so you have the histological changes. Complications, hepatic failure. Yep. GI varices, bleeding. Yep. Ascites and spontaneous bacterial peritonitis. Yep. Hepatorenal syndrome. Yep. Kidney failure due to liver dysfunction. Yeah. Progression to cirrhosis and hepatocellular carcinoma. Yeah, so you can see this progression, hepatic failure, then you're not making albumin, so you get the GI, the bleeding, right? You're not making enough proteins from the liver, so you get the protein imbalance, so you get the swelling and all that stuff and the edema and things like that because you don't have the protein balance, and you're at risk of spontaneous bacterial peritonitis, right? You're also at risk of hepatorenal syndrome, that is kidney failure, secondary renal dysfunction, and this can progress to cirrhosis and hepatocellular carcinoma. It's interesting how they come up with a progression of that. It's very useful. Management, absolute alcohol abstinence is the course of treatment. Correct? Yeah. Nutritional support, meaning high protein, high calorie diet. Corticosteroids used in severe cases based on measuring. Okay. Pentafoxylane, alternative if steroids are contraindicated. Management of complications such as lactose for encephalopathy, diuretics for ascites, liver transport for those with irreversible damage and abstinence. Prognosis, mild cases may recover with full abstinence. Severe cases, especially with jaundice and coagulopathy, have a short-term mortality. Severe cases such as jaundice and coagulopathy. So the jaundice means the fat disruption, in the fat metabolism, right? And coagulopathy is the disruption in the production of albumin and all those things that causes coagulopathy. So I guess when these huge systems fail, you have a high short-term mortality up to 30 to 50% at 1 month. Yeah, continued drinking leads to progression to cirrhosis and liver failure. Let me see here. This is very interesting to see here. Let me know if you have any questions, anything like that. Okay, let me see. Okay, would you like me to include how alcoholic hepatitis is different from viral or drug-induced hepatitis? Okay, how alcoholic hepatitis differs from viral and drug-induced hepatitis. Viral or drug-induced. Well, alcoholic hepatitis would be in drug-induced. Okay, that contrast often help clarify the mechanism and clinical management differences. Okay, sounds good. Cause. Okay, alcoholic hepatitis, then viral hepatitis, and then drug-induced hepatitis. Okay, the primary cause and then the mechanism action. So alcoholic hepatitis, Chronic and heavy alcohol use, often over 80 grams a day for years. Okay. The mechanism of injury is toxic metabolites of acetaldehyde, like we said, plus the oxidative stress creating the oxygen radicals, cause hepatocyte necrosis, inflammation, the battle cell death, the hepatocyte death, and then the inflammation. And then you have the immune response that activates, worsens the injury. Okay, that's the mechanism in alcoholic hepatitis. And okay, we went through that one. Okay, I did a previous lecture on hepatitis B. But I should have gone through the mechanism, how it destroys the cell too. So viral hepatitis. So it's an infection with hepatitis. It's a virus. Hepatitis A, B, B, the one I did is on hepatitis C. Okay, the virus infects hepatocytes. Okay, and then you have cytotoxic T cell mediated immune attack. It destroys the infected cells. So the virus infects the hepatocyte, and then you get a cytotoxic T cell mediated immune response that actually destroys the infected cell. So in alcoholic hepatitis, you get the buildup of acetaldehyde and the free radicals that damage the actual cells that results in inflammation, and then the immune response worsens the injury. In viral hepatitis, the virus in fact infects the hepatocyte that is recognized by the immune system, and the immune system initiates a immune response that results in the death of the cell. So you get the death of the cell through the immune response reacting to the virus infecting it. Got me? Okay, drug-induced hepatitis. Drug-induced hepatitis, medications or toxins such as acetaminophen overdose, isoniazid, valproate, methotrexate, and other psychotropics. All right. So these drug-induced medications, remember Depakote here is Depakote right here. Remember acetaminophen overdoses and everything is important to get cleared for those things. You know, this is called direct toxicity, meaning dose-related, or idiosyncratic hypersensitive reaction damages to idiosyncratic hypersensitivity reaction damages to hepatocyte. And so the drugs damage the cells directly. Okay. It's interesting to know the difference between them. Okay, clinical presentation. Alcoholic hepatitis, viral hepatitis, and drug-induced hepatitis. You have the onset of alcohol is gradual or acute after a binge. You'll get symptoms of jaundice, fever, right upper quadrant pain, anorexia, fatigue, like the liver is not feeling well. History clues, long-term alcohol use. The course can progress to cirrhosis. Okay, so this is the onset and clinical presentation of alcoholic hepatitis. Let's look at viral hepatitis. Okay, onset, acute or insidious depending on the virus. So you can get the symptoms right after infection, or they can develop over time. Okay, that's how it's sensitive. Okay, because this is infecting the liver, we're going to see the jaundice, all right, malaise, nausea, dark urine, right? Okay, history exposure, meaning the viral hepatitis, there's a sexual contact history, a needle, travel, or food leading to the viral, right? And the course is often self-limited with chronic with if it's hepatitis B and hepatitis C. Hepatitis B and hepatitis C are chronic forms, and hepatitis A and E is more of the acute forms. Okay, now here, drug-induced hepatitis, acute or subacute after exposure. So you get the hepatitis after you use the drug. Jaundice, malaise, nausea, possible rash, and eosinophilia, because the rash and eosinophilia may become in reaction to the drug or the substance that the drug is coated in or something like that. History, recent new medications or supplements, if they came in with new medication supplements or overdose or something like that. Of course, it improves after drug discontinuation unless massive necrosis and everything. And so this is what we want to do, like definitely do things like the activated charcoal and things like that to treat them. And that's drug-induced hepatitis. So I think it's You can see the difference between them. Let me see laboratory findings here. We're going to look at the AST-ALT pattern, bilirubin, alkaline phosphatase, and other markers. For alcoholic, since AST-ALT is 2 to 1. Okay. Now, AST is a marker for organ injury, but it's not specific to the liver, right? And so when you get other organs that can be under stress, you can get an increase in your AST. ALT is specifically connected to the liver, and we'll see the difference between these two and why it goes up like that. Okay, so here in alcoholic hepatitis is 2 to 1, bilirubin elevated, mildly phosphatidylate oxidase elevated, GGT and MCV escalated, increase. Viral, look, ALT greater than AST. Look, viral ALT greater, often greater by 1,000. And when you see this is a kind of dramatic presentation when you see this, because this is one of the indications that this is likely a viral hepatitis. Bilirubin elevated, ALK increase, other markers, viral serology. Okay, get your hepatitis panels and things like that. Great. Next, drug-induced. ALT is greater than AST, and it can be very high for drug-induced. Depends on how much damage, right? Bilirubin elevated can be high, especially in cholestatic injury, eosinophilia, and positive drug reaction markers. And so you'll know from your history. Yeah, so remember the distinction between this AST-ALT and then ALT-AST right here in drug use. It'd be interesting for you to remember. Okay, histologic findings. Okay, pattern. I'm not really going to get into that, the histological patterns. Let me see, management. It makes sense. The management makes sense. Alcoholics, stop drinking, and you have to focus on nutrition. Viral, you're gonna have to get your antivirals. Drugs, you got to stay away from the drugs. Prognosis, can be significant. And I think that's, we're at the 19-minute mark. I think that's it for today. All right, I think that's all I have for the day. Alcoholic hepatitis and cirrhosis. If you have any questions, please feel you can put something in the comment line. Otherwise, feel free to like, subscribe, and share. Read out. Take care, guys. Ciao.